Thank you, Tami. I will uh, I will talk about POCUS articles. What are important articles on the assessment of regional anesthesia complications? And I have no disclosures to announce. The first few articles, collection of articles, were from RAPM, Regional Anesthesia Pain Medicine. I implore you to be a member of ESRA so that you can access the RAPM website and all the academic content within the ESRA. So the POCUS is quite natural, a second nature of regional anesthetists, as we are used to ultrasound when at its inception, when we first practiced regional anesthesia. So having a POCUS is one of probably a small step that need to be taken to improve the management of patients. So this is an editorial in February 2020 talking about how a small step for mankind is a big step for point of care ultrasound. Stephen Haskins, who has been the author of many articles prior to this editorial, 2017, he published an article on focus, cardiac ultrasound for regional anesthetists and pain specialists, lung ultrasound, and followed in the 2020-2021 on gastric ultrasound, as well as the fast application in regional anesthetists and pain specialists. In the 2021, there were two important articles talking about how ASRA and ESRA coming together to have a standpoint on training of POCUS for regional anesthetists and pain physicians. The first paper was talking about clinical indication. So their training recommended the experts to report POCUS using the IAIM framework: indication, acquisition, interpretation, and management. So having a framework allows you to prove the implementation of POCUS on that particular point. Because in the US, it has got to do with reimbursement, insurance reimbursement. Having them properly done, showing and documenting that there is an indication of why POCUS needs to be done in particular situation, having an acquisition of an image documented, stored, documented, and reproducible, and having interpretation of the image with management. This is not a complete framework of reporting, but rather a shorter form of a focus reporting. That's what the word that was used, and it's accepted by the insurance for reimbursement. And the second paper was on recommendation, in which they come up with the recognition of barriers, with how training should be like. And although there are no established particular clinical pathway in the US itself, but there are academy and faculties and fellows here and there who've been trained under particular universities. For example, this was by a collection of authors from Duke University and Loma Linda in California. So they propose a training of level 1 of 30 POCUS images and level 2 of additional 20 POCUS images, both under supervision and reporting of individuals expert in the field as their supervisor. So what was called for the action was that to have a peri-operative POCUS rather than a normal POCUS that was known before before the era of regional anesthetists and pain physician doing POCUS, was only known as POCUS. So we have a peri-operative point of care ultrasound. This went on further. This author, Davinder Ramsingh, this paper is a free access paper. The rest, the earlier on, some of them, the POCUS papers some of them were free access. Introduce FORESIGHT. This is made in anesthesia. The FORESIGHT is an algorithm protocol that introduced a framework of point of care ultrasound made by anesthetists. Before, you have FAST, you have RUSH, you have all sorts of other algorithmic point of care ultrasound. Those are mainly coined by our emergency medicine colleague or other specialties. But FORESIGHT is made in anesthesia. In 2015, Davinder Ramsingh with his group introduced this. Stephen Haskin was also included. FORESIGHT stands for Focused Perioperative Risk Evaluation Sonography involving gastroabdominal, hemodynamic, and transthoracic ultrasound, focusing on how to get answer to a particular clinical situation or problem using pulmonary and cardiovascular scan, airway or optic scan, and abdominal or vascular access. The list is exhaustive and not limited. And Davinder Ramsingh went on further to have an assessment of impact. How much impact does a FORESIGHT training as a focus algorithm or framework had improved on patients' quality of care? So he went on to train in 2016, 24 specialist anesthetists in Duke University and Loma Linda Institute in California. And these 24 trained POCUS anesthetists performed within 2-year period, 2016-2018, 680 POCUS. And most of them were because of situation of cardiovascular indication. Second is pulmonary and abdominal. And it was done similarly, either preoperatively, or intraoperatively, and some in PACO, and very little of them were done in ICU. And the reason, the indication was because of the prior medical history, whether there was an unknown medical history, and whether this results in a positive impact on the patient's care. 50% of the time, it impact on different improvement in management of care for the patient perioperatively. So the patient will then return to the primary anesthesia provider, and the primary anesthesia provider will perform traditional assessment. TA is a traditional assessment. So they will compare the result of POCUS to answer a particular clinical situation with the result of traditional assessment by the particular anesthetist in charge of the patient. So what they found was that perioperative POCUS is 62 times more likely to be superior to traditional examination. There's a significant impact, you see. We cannot run away from this, especially when you are used to dealing with ultrasound in your regional anesthesia practice. So it can be done pre, intra, and post-operatively using different protocol. FORESIGHT has been advocated by Ramsingh and his group, whether to answer a particular indication of possible ventricular failure, massive embolus, pre-operatively and intraoperatively, to answer certain condition of the volume status, why is the hypotension persisting, or a question of hypovolemia, and other related to the pulmonary and abdominal situation. So coming back to the POCUS and risk of regional anesthesia, the next collection of article, which I think is important, in 2021, the AGBI journal produced list of I think 16 free to access articles. You can access the Anesthesia journal. If you're a member of MSA, the Anesthesia is actually one of the Ovid list of articles you can access to. But these are free online. The infographic was very nice. It tells us on the patient who will need to know some of the risks involved with regional anesthesia. For example, post-operative neurological outcome, you have 0.5 to 1% after RA, most resolved, very few, 1.5 actually develop permanent neurological injury. Incidence of LAST, 1 to 2 per 1,000 nerve block, and it can happen after operating theatre environment. And risk of pneumothorax is about 2.6% in paravertebral, 0% in ESP. And there are also other risks involved. In one of the articles in the collection of fundamentals and innovation in RA was articles on risk, consent, and complications related to regional anesthesia. Of course, this was related to mainly the National Audit for Patient Care, RA UK initiative, year 2005 to 2010, NAP3. Yeah. So in year 2000, there was a very tragic case mentioned on the, I think, a famous case where the nerve stimulator was used without ultrasound, and patient for interscalene block, giving analgesia for shoulder surgery. Patient became apneic, bradycardic, and lost his career as a concert violinist as the hand got paralyzed for end up in a long-term paralysis. One would wonder whether this could be prevented if we have proper assessment with ultrasound while doing block, and at the same time while managing possible complication as the patient came out of the block. So I will, in the next few slides, we'll talk about pneumothorax, how POCUS could assess in diagnosis of pneumothorax, hemidiaphragmatic paralysis, nerve injury, and last. When talking about, when communicating to patient with for risk of particular regional anesthesia, we have to communicate. It's advised to communicate using numbers, ratio, rather than percentage. 1 in 10, 1 in 100, 1 in 1,000. Having this, or whether using the word as in common, uncommon, rare, or very rare, rather than giving that percentage. Having a percentage is quite vague in their mind. And having this discussion on specific risks related to specific procedures is also important. So this is an example of how pneumothorax can be diagnosed. And most important is to identify the lung point. Lung point is specific for pneumothorax. Lung sliding is sensitive for pneumothorax. So you have lung sliding, you can rule out pneumothorax. But if you don't have lung sliding, you cannot rule in pneumothorax. You have to find lung point which can rule in pneumothorax. So in this, it is an example of having a collection of air around the sternum. You don't see any sliding sign, and this is your sternum here, internal mammary vessel, and you would see at this point some lung point lying just lateral to the sternum, and this is also another example of lung point. A second is on the diagnosis of possible hemidiaphragmatic paralysis. This study was published in Chest more than 15 years ago, about 15 years ago in 2009, describing how diaphragmatic excursion, whether in quiet breathing, in voluntary sniffing, or in deep breathing, can be a way to diagnose possible diaphragmatic paralysis. So the number is about 1.8 in quiet breathing and 5 centimeter of movement in deep breathing. Another revisit of the technique using a zone of apposition around the anterior chest wall is another technique to diagnose or to give a better way to approach the loss in hemidiaphragmatic movement using your liver as the window. So this will give us a better number compared to dome of diaphragm scanning. I can give you an example of a scanning for using just a linear probe after doing upper limb block, above clavicle block. You can scan over the right side of the patient. This is a normal patient. This is a ventilated patient. You could see that there is a lung sliding there, and following the intercostal. The key is to follow the intercostal space, and you could see this is the diaphragm sliding up and down, and that is the movement excursion of the zone of apposition. And at this point as well, you could also appreciate the thickness of the diaphragm as it moves, as it gets thickened during contraction, compared to the patient who's ventilated for pneumonia. You could see that the pleura is unhealthy. That is the lung point down there, at physiological lung point at the tip of costophrenic angle, and you see some fluid there, and that is the diaphragm that could be seen at the zone of apposition. This also can be seen on the left side, a bit more posterolaterally, by getting the spleen as your window. And that is an example of using the scan for assessing the movement of diaphragmatic dome using a Fesseray probe, looking at the mid-clavicle line subcostally. And your assessment is, in normal patient, you would see the diaphragm moving up and down, and you can also appreciate the lung, which appears to be normal compared to the posterior lobe lung on the ventilated patient which appear consolidated. Okay, So now moving on to how cardiac ultrasound might help us in the situation of hypotension, hypovolemia, or last. Three views on the subcostal, apical, and parasternal, looking at a four-chamber view or IVC view subcostally, or long axis view or short axis view in the parasternal region, and apical four-chamber to answer specific clinical indication for possible relevant pathologies. And this paper, Stephen Haskins also talk about possible situation that may be a problem to regional anesthesia or may come after regional anesthesia was performed in a situation where a patient had hypovolemia or massive pulmonary embolism, for example. Looking at the possible aortic stenosis is fairly easy by apical long axis scan. You could appreciate the thickened aortic valve, and by looking at possible hypovolemia by parasternal short axis, you could see that the area of the chamber in short axis is less underfilled in diastole and kissing each other in systole. And in massive PE, you would also see that the heart or the right side of the heart is well dilated with thin wall, and you could also appreciate the D shape in short axis. So one of the example of an article that talk about last in a patient with multiple myeloma and malignant lesion, possibly because of the low protein state and the angiogenesis or hypervascular state around the spine. Patient was having a lot of pain, resistant to the opioid given by the palliative team, and hence for MRI he was given epidural. But what transpired a few hours later, patient developed from hypertension, developed hypotension, and the transthoracic echo showed hypokinesia. The decision was then to give lipid emulsion, and subsequent to the lipid emulsion, you can appreciate that the contraction improved. And this is how POCUS could help you to appreciate the changes in the cardiac contractility. My last two slides is an article by Andrej Kroll looking at possible role of point of care nerve scan after peripheral nerve block. If you look at the updated RAUK peripheral nerve block follow-up for possible neurological dysfunction, if you have new onset neurological deficit, if it's consistent to nerve block that is involved, it is important to escalate for senior help and get ultrasound or MRI. And you could appreciate the size of nerve, radial nerve less than 0.1. It's an example of a case of mine in a hospital who had an interscalene block. And the surgeons were not particularly saying that our block was the fault here, but it was a worry that we also shared with the surgeon. So what we could appreciate from scan, I think 3 days after the block, patient had a wrist drop, and this is the long plate that is on patient's arm, and the surgeons was consistently saying that they are not anywhere near the nerve, but you could see here the nerve on the non-operating side, the size is 0.09 centimeter square, and the nerve on the operating side is about 0.15 centimeter square, definitely larger than the other side. And you could see a shadow of tip of the plate actually just lying next to the nerve. And you could also appreciate the nerve is actually larger by a double its size at the higher portion. So we could also appreciate this in a long axis. So this could help us to see, one, that possibly the axon injury is happening. Our neurophysiology consult will not give an immediate nerve monitor, what you call that, nerve testing or NCS or EMG immediately after surgery. They would wait for 6 weeks. And secondly, this could also assist our surgeon to see whether the nerve is actually impinged under their plate or near the plate. So this could help them and us in consulting the patient on way to follow them up and own the possible problem or issues. Thank you very much.